Hi, I'm Dr. James C. Wittig. I'm an orthopedic oncologist and sarcoma surgeon in the New York metro area. And today we're going to be talking about benign soft tissue tumors, namely lipoma, hemangioma, fibromatosis, myxomas, schwannomas, giant cell tumor of tendon sheath, and pigmented villonodular synovitis. These are tumors that affect the soft tissues throughout the body, namely the skin, subcutaneous tissues, the muscles, the connective tissue in between the muscles. They do not arise from the bone. They arise from the tissues around the bone in the extremities. For more information on various musculoskeletal tumors, please visit my website at www.tumorsurgery.org. First entity that we're going to speak about is the lipoma. A lipoma is a benign tumor, meaning it's not cancerous, it does not metastasize. It's composed of mature adipocytes or fat cells with uniform nuclei. The nuclei all look similar, identical to the cells of normal adult fat. The cells themselves look very uniform in nature, similar size and shape. Benign mature adipocytes have cytoplasmic lipid in a single large vacuole that pushes the nucleus to the periphery of the cell and compresses it into a thin crescent. So you see the nucleus at the periphery, it looks very thin and almost compressed and slit-like, as opposed to a lipoblast, which is present in a malignant or an immature fat cell. And this consists of a larger peripheral or central nucleus indented by one or more fat vacuoles so that spikes of chromatin project between the fatty vacuoles. It's usually smaller and have smaller vacuoles than mature lipocytes. There are many different types of lipomas. There's your standard lipoma, which is the most common. A fibrolipoma, which may have fibrous type tissue mixed with it, angiolipomas, which have blood vessels mixed with it, a spindle cell or pleomorphic lipoma, myxolipoma, lipoblastoma, myolipoma, hibernoma, which consists of brown fat, and a chondroid lipoma. Okay, lipomas are the most common type of soft tissue tumor. It primarily arises in adults, and most commonly it arises in the subcutaneous tissues. It can arise in the back, the shoulder, the neck, the abdomen, the proximal extremities. These are the most common areas. It's very uncommon in the hands, the feet, and the distal extremities. These tumors rarely recur after excision. They're very benign and indolent. There's no sex predilection. It occurs equally as common in males and females. It can also occur in the deep soft tissues or deep to the fascial layer. It could develop within a muscle or intramuscular lipomas. It develops within the skeletal muscle. It usually affects adults, but occasionally it's found in children. It primarily arises from the trunk, the large muscles of the arm, the thigh, the shoulder. Males are affected greater than females, and there's up to a 20% recurrence after excision, especially if it looks infiltrative. It infiltrates between the muscle fibers. Usually lipomas present as a slowly growing, asymptomatic, painless mass. Some patients may have multiple lipomas, and that's referred to as a condition called lipomatosis. Almost always lipomas are painless, although there are some that can cause some mild discomfort, such as angiolipomas, which are notoriously cause some discomfort or present with tenderness. Radiologically, lipomas on an MRI follow the same signal as subcutaneous fat. So sometimes you can get an MRI of a lipoma. It will blend in with the surrounding subcutaneous fat, and you can't even identify a mass on that MRI, and the MRI may be read as negative. On radiographs, you see a radiolucent soft tissue mass. Calcification may be present, particularly in areas of fatty necrosis. On CAT scans, you usually see a well-defined homogeneous mass. There's no enhancement following contrast administration on a CAT scan, and the tissue attenuation coefficient is low, usually minus 65 to minus 120 Hounsfield units. Again, the MRI follows the signal characteristics of subcutaneous fat on all sequences. On the T1 weighted image, it's a high signal. On the T2, it's intermediate, and on the T2, it's low signal when you suppress the fat. And there's minimal or no enhancement with gadolinium. This is an MRI of an intramuscular lipoma of the thigh with a very high signal on T1, and you can see this large mass in the thigh deep to the vastus lateralis muscle, and the signal intensity of the mass is the same as the subcutaneous fat. This is an MRI of the same lipoma, T2 weighted image that's fat suppressed, and you can see where the subcutaneous fat is suppressed, it's low signal intensity, and the lipoma is the same signal intensity as the subcutaneous fat. There's very minimal stranding in this, which is important because significant stranding is very suggestive of a low-grade liposarcoma, also referred to as an atypical lipoma or a well-differentiated liposarcoma. Here's another MRI, T1 weighted, of a lipoma of the posterior thigh. Again, very large mass, it's intramuscular, but it follows the signal characteristics of the subcutaneous tissue. And here's a T2 weighted image where this is not a fat suppressed T2. Fat is actually intermediate signal on pure T2 weighted images, and it's only when you perform fat suppression does it appear as a low signal. This is a T1 weighted MRI of a lipoma of the right shoulder. This is technically a fibrolipoma. That was the final diagnosis when it was removed. You can notice the stranding within the mass. So this is T1. It's mostly high signal lobulated contour in the T1 weighted image, but then you have these lower signal intensity or low signal intensity areas within it that are indicative of collagenous or fibrous septae. Now, these septations can also occur with low-grade liposarcomas and atypical lipomas. So certainly it can have these atypical lipomas or low-grade liposarcomas can have a very similar radiological appearance as a large fibrolipoma. And this is that same MRI T1 weighted image of the fibrolipoma in the shoulder girdle, and you can see how it's insinuated in the posterior aspect of the shoulder and the anterior aspect of the shoulder, wrapping around the scapular neck. This is a T2 fat suppressed image, and you can see the fat suppression in the mass and of the subcutaneous tissues. Normally the bone marrow is fatty in nature also, and you can see where the bone marrow is suppressed. This is a T1 weighted MRI of a large lipoma in the left thigh with a small area of fat necrosis. So this is the area of fat necrosis. Again, T1 weighted image, some slight stranding within it, and it has same signal intensity as a subcutaneous fat. We're going to speak about the pathology of a lipoma. On gross pathology, you see a soft, yellow, fatty mass, indistinguishable from normal fat. It usually grows in a lobular manner, and it may have a fibrous component reflected as white tissue within it. Muscle fibers may be present with intramuscular lipomas. This is the gross pathology of a lipoma, and you can see it's fatty in nature. It looks identical to what normal fat looks like, and they usually grow somewhat lobular in manner, and there may be some muscle fibers here if this was an intramuscular lipoma. Usually the subcutaneous lipomas are a little bit smoother in contour. This is the gross pathology of that lipoma that had an area of necrosis within it. So you can see the yellow fat. This is transected longitudinally, and the area of fatty necrosis in the center of it. Microscopically, lipomas consist of mature fat cells with small uniform eccentric nuclei. The nucleus is compressed against the periphery of the cell membrane by a large fat vacuole. There are no mitotic figures. You can have areas that undergo fat necrosis. Muscle fibers may be interspersed amongst mature adipocytes for intramuscular lipomas, and you can have other components to the lipoma: fibrous tissue, myxoid tissue, and blood vessels. Myxoid tissue is mucinous type of material. This is showing you the low power view of a lipoma, microscopic pathology, and you can see the cells all look uniform. They look similar size and shape, and you don't see any nucleus in the center of the cell. You look at the periphery of the cell and you may see a small condensed nucleus. It's a little bit hard to see on this low power view, but everything looks mature here. There's no mitotic figures. On higher power view, you see here where the nuclei are compressed up against the periphery, and all you see are these large fat vacuoles, and it looks very uniform. Everything is arranged in a uniform manner of similar size and shape. This is a histological example of mature fat. Okay, again, benign appearing, similar size and shape of the vacuoles, and the nuclei are compressed up against the periphery in a small slit-like manner. Right here, here's the nucleus, here's the nuclei of this cell, here's the nuclei of this cell, here's the nuclei of this cell, and these look different than what a lipoblast would look like. Again, high power view, and here you see the compressed peripheral nucleus associated with a benign lipoma. Again, the compressed nuclei, which are barely discernible in some examples of benign lipomas, whereas a lipoblast or a well-differentiated liposarcoma may have the nucleus in the center, or with stranding out from with chromatin stranding out, a very irregularly shaped nucleus. Okay, the differential diagnosis of a lipoma is really an atypical lipomatous tumor or a well-differentiated liposarcoma. They go by these two names usually. They can both look identical on an MRI. Well-differentiated liposarcomas, however, may more commonly have stranding within it and thick strands of thick stranding on the MRI. Histologically, well-differentiated liposarcomas have larger nuclei, the presence of lipoblasts, and considerable variation in the size of the fat cells. Few points to keep in mind in terms of location. Lipomas do not occur in the retroperitoneum. Retroperitoneal fatty tumors are capable of recurring and dedifferentiating even if they look histologically bland, similar to a lipoma. So retroperitoneal fatty tumors should be considered malignant or a low-grade liposarcoma at the least. In terms of the treatment and prognosis, lipomas are benign and they do not metastasize. They're not treated with any forms of chemotherapy nor radiation. They're not fast-growing tumors. They do not metastasize or spread. They're cured with removal. You can observe small asymptomatic lipomas. In surgery usually consists of a marginal excision for symptomatic, large, or deep lesions or tumors which are growing. Local recurrence. The risk of local recurrence depends on size and location of the lipoma. Rarely does a subcutaneous lipoma recur, and intramuscular tumors may recur up to 20% of the time. The next entity we're going to speak about is a hemangioma. A hemangioma is a benign proliferation of mature vessels. Okay, it can be composed of capillaries, veins, or a combination of both. The vessels can vary in size and shape, and there's a broad variety of hemangiomas with varying clinical presentations and biological activity. The most common sites are the skin, the subcutaneous tissue. They can occur intramuscularly. they can occur intra-articularly or from the synovium, referred to as a synovial hemangioma, and actually they can occur in the bone, so they can really occur any place in the body. Intramuscular hemangiomas are often larger than cutaneous hemangiomas. They're more often symptomatic than cutaneous hemangiomas, and they recur more often than cutaneous hemangiomas. Intramuscular hemangiomas are composed of morphologically benign vascular channels occurring within skeletal muscle. They almost always are associated with varying amounts of fatty tissue. So if you get an MRI, you can see the blood vessels. It's usually not a well circumscribed discrete mass, and you may see varying amounts of fat within this admixed with the blood vessels. So very characteristic. The blood vessels and the vascular channels are often mixed type of venous and capillary types of vessels, and you may even see phleboliths, which are calcifications that occur in the blood vessels, which are more readily picked up on an X-ray. In terms of intramuscular hemangiomas, adolescents and adults are most frequently affected. Males are affected as commonly as females. Most commonly occur in the lower limb, the head and neck, the upper limb, the trunk, and rarely in the retroperitoneum and the mediastinum. It clinically presents as a slowly enlarging, often long-standing mass. They're usually painful when they present. Pain is worse after exercise, and they change in size according to position of the limb, which is very important on physical examination. If you suspect a hemangioma, examine the limb in different positions and see if the mass gets bigger or smaller depending upon the position of the limb. Now, hemangiomas are not true tumors or neoplasms. They're really considered congenital malformations. Most people are born with them, but they may become symptomatic at some point during their life, or they may go completely asymptomatic and be found incidentally. In terms of an intramuscular hemangioma, X-rays are usually normal. You may be able to identify phleboliths or stromal bone formation, which occurs in 30 to 50% of cases. There can be pressure erosion of an adjacent bone or extension into the bone with channel-like radiolucencies. So you may have a hemangioma with also adjacent bony involvement. CAT scan usually shows a poorly defined lesion with attenuation similar to muscle, and there's usually marked contrast enhancement of serpentine-like vascular channels, so it must look snake-like. Subtle phleboliths and lesions adjacent to bone rarely stimulate a subtle periosteal reaction. So they could irritate the surface of the bone, and you get a very subtle periosteal reaction on the bone. The MRI appearance of a hemangioma is usually heterogeneous, poorly marginated mass on the T1 weighted image. High signal intensity areas on T1 demonstrate fat overgrowth within the mass or the presence of fat. Heterogeneous, well-defined mass on T2. Vascular channels are usually high signal on T2 because of their slow flow through the vessels. There may be hemorrhage and prominent enhancement, and they infiltrate surrounding structures. They don't displace them or destroy them, but they infiltrate. So you don't see, like in a sarcoma, where the border of them is pushing the muscles away. It will infiltrate into the adjacent muscles. This is showing an X-ray of a hemangioma of the forearm, where you should take notice of these phleboliths, which stand out, which indicates bone formation within the actual mass. Here's that same hemangioma on an MRI. Okay, there's significant fatty tissue in it, which is similar in signal intensity to the skin on the T1 weighted image, and then these low flow, low signal or intermediate signal intensity areas similar to muscle, which are the vessels. And you can see how it's not, these vessels are serpentine-like, they're not discrete and round and ball-like. This is showing you the T2 weighted image, where you see this very high signal within the actual vessels, and how the vessels are serpentine-like and irregularly shaped and infiltrate through the surrounding muscles. They don't grow in a ball-like manner like a sarcoma. Here's an example of hemangioma in the calf. Intramuscular hemangioma on the T1 weighted image here and the T2 weighted image here. You can see the T1 weighted image, there's significant fat within the mass, similar to the bone and similar to the subcutaneous tissue. On T2 weighted image, you see very high signal, and it has somewhat of an irregular border, and it looks like the vessels are in the shape of worms. This is an intramuscular hemangioma of the vastus medialis muscle, and here's a T1 weighted image. There's no fat in this mass. The vessels are similar to signal intensity to muscle, and here's a high signal on T2 weighted image with an irregular border. Here's another view of a hemangioma, T1 and T2. Here's the axial view of that same hemangioma, the T2 weighted image, where perhaps there's some involvement of the bone, but here is very irregular serpentine-like channels or vessels that are high signal because of the slow blood flow through them. Here's the sagittal of that same hemangioma, T1, T2. Very little fat in this hemangioma. Okay, let's talk about the pathology of an intramuscular hemangioma. The gross pathology will show large, poorly demarcated, yellowish tissue, which looks fatty in nature, especially if it's got a significant amount of fat in it. You'll see vascular and hemorrhagic areas, and there may be focal calcification or ossification if there's phleboliths that are present. On microscopic pathology, you usually see mixed vessel types of both capillaries and veins. It's lined by normal appearing single layer of epithelial cells. It diffusely infiltrates muscle and entraps muscle cells, leading to degenerative bizarre muscle cells. And you may see a prominent adipose component. This is a low power view of a intramuscular hemangioma, and what you see are these vascular spaces here filled with blood cells. You see fat. These are all lipocytes filled with vacuoles filled with fat, and you see here the skeletal muscle that's involved by the hemangioma. So, and you see both capillary type and which have very capillary type of blood vessels, as well as venous type of blood vessels. The venous blood vessels have very thin walls, whereas the capillary vessels or the arterial side have thicker walled vessels. So there's a mixture here, but the key is identifying the vessels with the red blood cells within it, the skeletal muscle, and the fat. Hemangiomas often have associated fat within them. Showing you a high power view. This arrow is pointing to the fatty tissue that's within it, that you could identify on the T1 weighted MRI. This is skeletal muscle in this location, and you see this is a vein. This is venous over here. This is more capillary-like or arterial-like with the thicker wall. Okay, and then you see the red blood cells in these large vascular channels. There's an area where there's a significant amount of muscle tissue and the different vascular channels. Very large venous channel over here, fatty tissue, and a thicker arterial type vessel on this side, and capillaries over here. Again, hemangioma, you're looking for the vascular channels and the fatty tissue. Another good example of hemangioma, showing you all the blood vessels, multiple blood vessels filled with red blood cells. There's no bizarre features. The endothelial cells are lined up nicely. These are true vascular channels, not like an aneurysmal bone cyst where there's no lining. These are all lined by endothelial cells that form very nice, mature looking vascular channels. Okay, and you have a mixture of capillaries and veins in this high power view. Okay, the next entity that we're going to speak about is fibromatosis, which is also called desmoplastic fibroma. It's also referred to as an extra-abdominal desmoid tumor. Fibromatosis is benign. It's not cancerous. It does not metastasize, and it consists of infiltrating fibroproliferative neoplasm. Fibro meaning it's fibrous tissue. It's composed of fibrocytes, fibroblasts, and myofibroblasts within a collagenous to myxoid stroma. So you can have a lot of fibrous tissue, and you may see some myxoid areas or mucinous areas. The cells have a uniform bland nuclear features, and infiltration of skeletal muscle occurs routinely. These tumors are very infiltrating and have a high propensity for local recurrence after excision because they extend out microscopically much further than what you can identify with the naked eye. And like I said, a high propensity for local recurrence with surgical resection. Fibromatosis occurs most commonly between the ages of 15 to 40. However, it's been described in all age groups. When it occurs in a patient less than age 5, it's referred to as infantile fibromatosis, and females are affected slightly more than males. The most common sites, it particularly likes to occur around the shoulder girdle and the upper arm. That is really the most common site, followed by the buttock, the trunk, the head and neck. The hands and feet are very rare sites, and 10% are multicentric and usually involve an anatomic area, although may develop in unrelated areas. Patients usually present with a mass or swelling that may be mildly painful or painless. So it can cause pain or it may be painless. Usually that swelling is extremely firm in nature. Plain radiographs usually show a nonspecific mass. Bone involvement may be present, but usually is due to pressure erosion or scalloping if present. It doesn't directly invade the bone. There's no mineralization within it, and bone involvement is more common with recurrences. CAT scan usually shows a poorly defined mass with an irregular margin. It often extends out with what looks like to be tentacles, and it enhances with IV contrast, which actually does not correlate with lesion vascularity. MRI demonstrates a mass with an infiltrative growth margin. You have these tentacles that stick out from the mass that invade adjacent tissues. It does not grow like a ball like a sarcoma. Sarcomas grow very ball-like. On the T1 weighted image, you usually have an intermediate signal intensity similar to muscle, and the T2 weighted image, it could have a variable appearance. It's usually heterogeneous, but it may be low signal if it's hypocellular and there's a lot of collagen formation. Maybe high signal with hypercellularity, myxoid change, and mucopolysaccharides. Identification of low signal areas on all pulse sequences indicates dense collagenous areas. And usually they enhance markedly with gadolinium. 10% of fibromatosis will not enhance with contrast. This is showing a T1 weighted MRI of a fibromatosis in the shoulder girdle up against the chest wall. And you can see it's not really growing like a ball. It grows within a regular border, and it's intermediate signal similar to muscle on the T1 weighted image. This one is involving the serratus anterior muscle. This is the T2 weighted image. It's very high signal on the T2 weighted image with some low signals areas in it. The low signal areas are more collagenous areas. These high signal areas indicate myxoid change or more cellular areas. This is a T1 weighted MRI showing a fibromatosis of the right buttock muscle. Again, grows somewhat irregularly and not ball-like. This is T1, its intermediate signal on the T1 weighted image. This is a T2 weighted image, and majority of the mass is very low signal on the T2 weighted image, indicating there's an extensive amount of collagen in this and a significant fibrous component, but there are some high signal areas within it. And this is an MRI with gadolinium of that same mass, and you can see how the entire area of the mass lights up, where you have this irregular border to it. It's sticking out like tentacles in the adjacent muscle that you may have missed on the standard T1 and T2 weighted images, and you can see how it enhances avidly with the gadolinium enhancement. Here's an example of fibromatosis in the foot where it caused a pressure erosion of the adjacent two metatarsals. And this is showing you the MRI appearance of that fibromatosis. Fibromatosis is rare in the hands and feet, but it can occur, and it grows in a very infiltrative manner. Let's talk about the pathology of fibromatosis. Most tumors are large. They're 5 to 10 centimeters and up to 20 centimeters in diameter. You have a glistening white fibrous tissue when it's transected. Myxoid areas or mucinous areas may be noted, and they infiltrate skeletal muscle at the periphery. Microscopically, fibromatosis is usually hypocellular to a moderately cellular lesion. There's no atypia in these cells. They all look very bland, small, monotonous, and there's usually a lot of matrix compared to the cellularity. See elongated, uniform, bland fibroblasts and myofibroblasts loosely arranged in bundles. Collagenous to myxoid matrix, which resembles scar, fascia, fibrous tissue, tendon, can have a similar appearance. So you have to watch when you're checking your margins during surgery. If you hand them a piece of fibrous tissue, it can look similar to a fibromatosis. The collagen bundles are often wavy in fibromatosis, and sometimes they're large, thickened collagen bundles. It infiltrates skeletal muscle at the periphery, and there's numerous thin-walled compressed vessels that appear slit-like. So you see these slit-like vessels throughout the mass. Okay, here's a gross pathology of fibromatosis, and you want to notice it looks very white in nature, and you can actually see these fibers or these kind of wavy bundles of fibers throughout the mass. Okay. It feels very firm and rubbery in nature. Over here, this area looks more myxoid or mucinous, and over here, densely collagenized, and over in this location also. This is showing you a low power view of the histology of fibromatosis, and this one is fairly hypercellular. The nuclei all look very bland. They're small, they have a similar appearance, but you see these wavy collagen fibers in the mass. Okay, and then these small slit-like vessels that are scattered throughout the mass. Fibromatosis can be very vascular. Okay, but wavy collagen fibers and nuclei all look similar size and shape, and there's a lot of matrix here in collagen. This is a higher power view of fibromatosis, and you see the collagen fibers. They're wavy in nature, and even the nuclei. The nuclei are spindle shaped and they're somewhat wavy in nature. The more wavy ones are more consistent with myofibroblasts, where there's some contractile properties to them. Again, high power view of the wavy collagen fibers in fibromatosis. Look over here, you see this pink staining fibers that look very wavy. And over here, you look very closely and you can see, actually make out the individual fibers and how wavy they look. And up in this location, the nuclei look very bland. They look similar to each other. There's a lot of matrix here compared to the cellularity, but this is actually a moderately cellular fibromatosis. It could be much less cellular than this. This is another gross specimen of a fibromatosis, and you can see here where the fibromatosis, you see, first of all, you see it has a white glistening surface, and you can see the fibers here, the fibrous dense collagenous tissue, and how it grows out into tentacles into the adjacent muscle. And here's your muscle layer here, and over here this is your individual muscle fibers, and you can see the fibromatosis growing in between each of the bundles. It grows in a very irregular manner. It's not one big ball pushing the fibers away, it's insinuating in between all the muscle fibers. Again, look at this closer view of the gross specimen. Look at the swirling nature or the wavy nature of the individual fibers. Okay, and with areas in between that look more myxoid in nature. Again, this is another low to intermediate power view of fibromatosis. Notice the wavy collagen fibers and the nuclei that look all similar size and shape, very bland. There's no large irregular nuclei. They all look similar to each other. It's not a hypercellular tumor. Okay, there's no pleomorphism, there's no mitotic figures, and you see lots of matrix with these wavy collagen fibers and small vascular channels. These look like capillaries. Over here, small slit-like vascular channels. Higher power view showing you the collagen fibers, the wavy collagen fibers, and all the spindle cells. Again, this is a densely collagenized area. You see this one big strand here, a bundle with all the individual collagen fibers in it, and it's very hypocellular. When the nuclei are very bland, there's no pleomorphism, they all look similar to each other. High power view, you want to take notice of the nuclei. They're all very bland looking. There's no mitotic figures. There's lots of matrix here with these wavy collagen fibers. Collagen fibers stain pink because of the collagen component or the fibrous component. Differential diagnosis of a fibromatosis is usually fibrosarcoma. Okay, it can be very difficult histologically to differentiate fibromatosis from a grade 1 fibrosarcoma, although fibrosarcomas usually grow more ball-like and with less of an infiltrative border. Fibrosarcomas are usually more cellular. They usually have abnormal chromatin and usually have abnormal mitoses greater than 5 per high power field. They grow more ball-like and are less infiltrative, although the radiographic appearance can be similar. Fibromatosis is benign, non-metastasizing, locally aggressive, meaning it grows locally into the adjacent soft tissues and has a propensity for local recurrence following resection. Local destruction of vital structures can lead to death. So for instance, a fibromatosis next to the thoracic cavity can grow in through the thoracic outlet and into the mediastinum. So it can cause a very big local problem there. So they can be very locally destructive and cause some major problems, although they don't metastasize. Treatment. Surgery is really the mainstay of treatment, which usually requires a wide excision. The local recurrence rate is usually at least 20%, but depends on the size, location, and surgical margin. So if you're going to answer surgical resection for this type of tumor, it's either a wide or radical resection. Okay. Radiation is very controversial. It may be considered postoperatively for close or microscopically positive margins depending on the site and multiple patient factors and if the tumor is recurrent. There's been no definitive proof that radiation helps control local disease, although in In some instances, it may be beneficial, but very controversial. Chemotherapy is also somewhat controversial. There are some chemotherapy regimens that do work on fibromatosis and will cause it to regress over the course of time. And when that chemotherapy is stopped, the tumor usually does not recur after it's stopped. These are utilized in very selected situations, usually for tumors that are in fairly inaccessible locations, or where resection will cause an extensive amount of morbidity. And there are various different types of chemotherapy regimens that are utilized for it. Okay, next entity we're going to talk about is myxoma. Myxoma is a benign hypocellular tumor with sparse vasculature. Okay. Consists of bland spindle to stellate fibroblasts within an abundant myxoid or mucinous stroma. It's a rare tumor. It occurs in one case per 1 million people. Adults are affected usually between the ages of 40 to 60 years of age. Females are more commonly affected than males, and there's very rare childhood cases. Most common sites of origin include the thigh, the gluteus maximus, and the upper arm. A myxoma is a slowly growing mass. It's usually painless. The size is usually between 5 to 10 centimeters. Patients may present with multiple tumors, however, this is rare. This occurs in 5% of patients. And when it does occur, it may be associated with fibrous dysplasia of the underlying bone, or in cases of multiple myxomas, Mazabraud syndrome, Mazabraud, Mazabraud syndrome. Let's talk a little bit about the radiology of a myxoma. Radiographs, or plain x-rays, usually show a normal or nonspecific soft tissue mass. Myxomas really do not mineralize. You rarely, if ever, see calcification deposited in a myxoma. CAT scans show a well-defined homogeneous soft tissue mass, and there's usually no enhancement with contrast when used with a CT. The MRI appearance is similar to fluid or ganglion cysts. Also, myxoid sarcomas can have a similar appearance. On the T1, it's a homogeneous mass. The signal is lower than muscle. On the T2, you have a markedly high signal intensity. It almost looks like a light bulb lighting up. Very similar to a ganglion cyst or fluid. And that's because of the mucinous nature of the tumor and the glycosaminoglycans and the hyaluronic acid, which traps water and shows up as a high signal on a fluid-sensitive sequence, such as a T2 weighted image. And usually when there's gadolinium that's administered, usually there's peripheral and septal enhancement, although there may be some heterogeneous enhancement with gadolinium. However, this is important for differentiating a myxoma from a ganglion cyst. Ganglion cysts should not have any enhancement with gadolinium administration. This is showing you a T1 MRI of a myxoma of the triceps muscle. And you can see it's fairly low signal, it's fairly well circumscribed, looks like a ball in the triceps muscle. This is showing you the same myxoma on the T2 weighted image. Very high signal. It looks like a light bulb. Okay, very unusual to get a cyst, an intramuscular cyst. So one should not say definitively that this is a cyst, because all sorts of myxoid tumors, there are some types of myxoid sarcomas that can have a similar appearance, that show a very high signal intensity on the T2 and have a MR appearance very similar to a cyst. This is showing you a myxoma of the triceps muscle. This is your T1 weighted image. This is your T2 weighted image. And it's showing you the high signal on the T2 weighted image, or this is a fluid sensitive sequence, and the low signal on the T1. This is an MRI of a myxoma of the thigh. Low signal here on the T1 and very high signal on the T2. Again, a myxoma of the thigh. Low signal on this T1 weighted image and high signal on the T2. This is the gross pathology of a myxoma. Okay, it's usually round to ovoid and very well circumscribed, and usually has a gelatinous appearance to the surface. It's a pale mucinous or gelatinous surface. There's usually no necrosis or hemorrhage in it. Necrosis and hemorrhage may indicate a myxoid type of sarcoma, such as a myxoid liposarcoma or a myxoid MFH. Again, what you're noticing on this closer view is the mucinous surface. Microscopically, a myxoma consists of a poorly circumscribed infiltrative lesion. It merges with the surrounding skeletal muscle and fascial tissue. It's hypocellular, spindle and stellate cells with pale cytoplasm and dark hyperchromatic small nuclei. There's a myxoid or mucinous stroma. It stains pale blue because of the hyaluronic acid or the mucopolysaccharides. There's no nuclear atypia or pleomorphism. There's very rare mitotic figures. There's no abnormal mitoses, and it's vimentin positive. This is showing you the intermediate power view of a myxoma. There's all this pale staining mucinous tissue with some fibrous stranding within it, and all these tiny little nuclei that all look similar in size and shape to each other, very hypocellular with lots of matrix or mucus production. There's another view of a myxoma, very bland looking, hypocellular with mucinous type material throughout it. The differential diagnosis of a myxoma consists of other myxoid neoplasms that can appear identical on an MRI. Myxoid MFH, also called myxoid UPS, undifferentiated pleomorphic sarcoma, myxoid liposarcoma, a myxoid schwannoma, a myxoid leiomyosarcoma, myxoid malignant peripheral nerve sheath tumor, and a ganglion cyst. They can all look very similar, but the histology is different, and their biological behavior is much different. In terms of the treatment, remember this tumor is benign. It does not metastasize. It grows slowly but in a non-destructive manner. The treatment is marginal excision. Okay, it's not a destructive tumor. You're going to marginally excise it. It locally recurs in less than 5% of cases, and there's a very low risk of recurrence even when residual microscopic disease is left behind. Next entity we're going to speak about is a schwannoma, which is also called a Neurilemmoma. A schwannoma is a benign tumor arising from a peripheral nerve sheath, or the epineurium. It's the coating around the nerve, and it's derived from a Schwann cell, hence its name schwannoma. Represents 5% of benign soft tissue tumors. Primarily occurs in adults 20 to 50 years of age, and it usually occurs along the major peripheral nerves in the upper and lower extremities and the head and neck region. It is usually painful and very painful. It usually grows very slowly and usually grows to a size that's less than 5 centimeters. It's usually associated with a positive Tennelle sign, although not everyone is painful and not everyone is associated with a Tennelle sign. Tennelle sign is when you tap on it, you get pain that radiates down the extremity, or electric-like shocks more distal in the extremity. Schwannomas tend to be mobile in the transverse plane, but not in the longitudinal plane, because they usually grow along the long axis of the nerve, so you can move them back and forth transversely, but not proximally and distally when you're palpating them. Again, schwannomas arise from the periphery of the nerve, the epineurium. The nerve or the nerve fascicles is displaced eccentrically from the schwannoma, which enables you to remove the schwannoma. The schwannoma does not infiltrate in between the individual nerve fibers or fascicles. Small cutaneous nerves may appear to be obliterated by the tumor. Plain radiographs are usually normal, and the CAT scan usually demonstrates attenuation on the non-contrast CT lower than muscle. MRI usually shows an intramuscular mass. So remember, your nerves travel between the muscles, closely related to a neurovascular bundle with a distinct margin surrounded by a rim of fat, which is called the split fat sign. So usually you see with a schwannoma, there's fat that's surrounding it that separates it from the muscle. And remember, your neurovascular structures run intramuscularly between the muscles in the fatty tissue. It's usually fusiform, elongated, and cigar-shaped. And you may see a tubular structure entering and exiting the mass. It may be difficult to see with small lesions or lesions of the trunk or retroperitoneum. Spine lesions are usually dumbbell-shaped, exiting from an enlarged neural foramina. So you may see that the mass, part of it is within the spinal canal and part of it sticking out of the neural foramina, and it makes it look somewhat dumbbell shaped. On a T1 weighted MRI image, the schwannoma is usually same signal intensity as muscle or intermediate signal with variable enhancement with gadolinium. On the T2 weighted image, you usually see a high signal, which indicates the myxoid areas of the schwannoma with some heterogeneity or some low signal areas. And there may be a target sign, which is very characteristic of a schwannoma, a low signal central area, which indicates the cellular or the collagenous area, and a high signal peripheral area, which is the myxoid area. So you see the target sign on the T2 weighted image. Low signal in the center, indicating the cellular and fibrous area or collagenous area, and high signal around the periphery, which is more of the myxoid area, referred to histologically as Antony A and Antony B areas. Histologically, on microscopic pathology, schwannomas consist of an Antony A area and an Antony B area. The Antony A area is the cellular area arranged in short bundles or interlacing fascicles. The Antony B area is less cellular and more myxoid. There's an entity called an ancient schwannoma, where there can be cyst formation, calcification, hemorrhage, and fibrosis. It can give you an appearance similar to a malignancy on an MRI scan, or similar to a high-grade sarcoma. Ancient schwannomas, however, are benign. They may be greater than 5 centimeters. Most schwannomas never grow greater than 5 centimeters. A schwannoma that's greater than 5 centimeters should be suspected to be a malignant peripheral nerve sheath tumor. Schwannomas stain S100 positive. Here's a characteristic target sign on the MRI. This is the T1 weighted MRI and the T2 weighted MRI of a schwannoma. And you see the schwannoma is primarily intermediate signal on T1, high signal intensity on the T2 around the periphery of the mass, and the more central area, which is the Antony A area, the cellular or fibrous area, is low signal on the T2 weighted image. So this is a characteristic target sign of a schwannoma. This same schwannoma, T1 and T2 weighted images. T2, you see the characteristic target sign. It's in the vicinity of the neurovascular structures, intramuscular. You do not see here, however, the split fat sign because of its location in the arm. This is showing you an MRI, the MRI again in a different plane. This is in the sagittal plane, and you're seeing this long tubular structure enter into the mass and exit. On the T2, it may be easier to see it. Here's this tubular structure entering into the mass and exiting it down below, and you see these low and high signal areas within the mass. The mass is somewhat oblong or cigar shaped. Again, this is an MRI of schwannoma, the median nerve. You see here the split fat sign, where the fat is surrounding the schwannoma. The schwannoma is intermediate signal similar to muscle on the T1 weighted image. And this is a T2 weighted image where you see these low signal areas and mixed with the high signal areas more around the periphery. This is showing you the surgery for a schwannoma along the radial nerve. can see, I'm sorry, along the median nerve, that is, and you can see the schwannoma here is oblong or cigar shaped. Here's the median nerve entering the mass and exiting the mass, and here are the blood vessels that have been retracted and separated from the schwannoma so that the schwannoma can be safely removed. You can see here where the fascicles are splayed off for the deep side of the mass, and the schwannoma here is eccentric. So in order to remove this, you would open the sheath, the epineurium, on the side opposite of where the nerve exists, or where the nerve fascicles are splayed across the mass. And you can see once the epineurium is open, it can be peeled off of the schwannoma, and the schwannoma can be gently enucleated from the nerve sheath, leaving the fascicles intact. And this is just showing you after it's removed how the fascicles remain intact and the nerve remains intact where it was located at the periphery of that large mass. And you leave the sheath intact also. You don't close the sheath after you remove the tumor. If it bleeds a little bit in the sheath, you wouldn't want the blood to fill up and compress the nerve. This mass was almost 4 centimeters. It has somewhat of a gelatinous appearance because of the myxoid component around the periphery. This is showing you the gross pathology of a schwannoma, and you see the myxoid nature of it, particularly around the periphery, perhaps more collagenous in the center. Got another schwannoma, somewhat myxoid in nature, particularly around the periphery, maybe more fibrous in the center. This is showing you the microscopic histology of a schwannoma. Okay, this is the Antony A, or the cellular area. Okay, where you see the palisading nuclei and the tissue that resembles nerve-type tissue. Nerve fascicles. Again, Antony A areas where you see these verrucae, they're called. The way the nuclei are palisading and lined up next to each other. These are verrucae bodies. Here's a close-up or a high-power view where you see the nuclei that are palisading. They're arranged in fascicles at different angles to each other. The nuclei all have a similar size and shape, have a very bland appearance. There's no mitotic figures. All benign characteristics. And then this is an Antony B area, which is the myxoid area. Again, looks almost similar to a myxoma, where you have all this fluffy myxoid type of mucinous material that gets washed out with the staining process, and these tiny little nuclei scattered throughout, which are all similar size and shape, very bland appearance. Another example of an Antony B area, very myxoid in nature, relatively hypocellular. There's space between all the cells. There's lots of matrix and a myxoid type of matrix. And this is showing you the verrucae bodies, very classical verrucae bodies in a schwannoma. Okay, where the nuclei are arranged around the periphery of this neurogenic tissue, the nerve fascicle tissue. The treatment for a schwannoma consists of surgical excision. It's a marginal excision that's performed, and the nerve is spared from excision. You do not remove the nerve to remove a schwannoma unless it is a malignant peripheral nerve sheath tumor. This is a benign tumor. It does not metastasize. The local recurrence rate is extremely rare. It's less than 1%, and malignant degeneration is extremely rare. Neurofibromas are different than schwannomas. They constitute 5% of all benign soft tissue tumors. 90% are solitary lesions unrelated to neurofibromatosis. It usually affects young adults ages 20 to 30, and it usually arises in the superficial nerves in the dermis or the subcutaneous tissue, and it rarely affects larger nerves. Clinically, patients present with a painless mass, whereas schwannomas are painful. They're usually less than 5 centimeters and they're slow growing. They actually infiltrate beyond the epineurium into the nerve or in between the nerve fibers. It's not encapsulated. It cannot be separated from the nerve. So you cannot remove these without removing the nerve. So you would only remove these if there was malignant degeneration or it was technically a malignant peripheral nerve sheath tumor. Histologically, neurofibromas consist of interlacing bundles of elongated cells with wavy, darkly staining nuclei and significant amounts of collagenization. There's no Antony A or Antony B areas. Solid and fleshy tumors. They're rarely removed surgically since they are not painful, and you cannot remove without removing the entire nerve. Solitary neurofibromas rarely, if ever, undergo malignant change, and malignant transformation usually occurs in the setting of neurofibromatosis. Persistently painful lesions usually indicate malignant transformation to a malignant peripheral nerve sheath tumor, and these tumors are usually greater than 5 centimeters in size. Okay, the next entity that we're going to speak about is giant cell tumor of tendon sheath. Giant cell tumor of tendon sheath is not the same thing as giant cell tumor of bone. Okay, it's more or less the same thing as pigmented villonodular synovitis, at least histologically, but PVNS that occurs around a tendon or associated with the tendon sheaths. It's a localized nodular tenosynovitis. It's a localized or diffuse proliferation of synovial-like cells, giant cells, inflammatory cells, and xanthoma cells along tendon sheaths. It usually occurs in the 3rd to 5th decades. It's the most common benign soft tissue tumor of the hand. It can erode into the bone and destroy it. So it's important to remove it because it can be locally destructive. The most common sarcoma in the hand is an epithelioid sarcoma. The giant cell tumor of tendon sheath usually occurs in the hand and wrist and metacarpal locations in about 65 to 89% of cases. It also occurs in the foot and ankle in 5 to 15% of cases. It can cause pressure erosions in the adjacent bone, especially in the ankles and feet, and it does not calcify. Calcification is extremely uncommon in giant cell tumor of tendon sheath. And here's an example of one in the hand in this location. On an MRI, giant cell tumor of tendon sheath is iso-intense to muscle on a T1 weighted image. So you can see here, similar in signal intensity to the muscle. It's heterogeneous on T2 weighted images with low and high signal areas. The dark areas on T2 represent hemosiderin usually. Hemosiderin usually blooms on a gradient echo, so you may want to order special images with gradient echo images to demonstrate blooming artifact, and which means that the hemosiderin actually blooming means it becomes darker on the gradient echo sequence than on the T2 weighted image, and it may demonstrate intense enhancement. This is just showing you various MRIs. You can see this tumor related to the tendon sheath. Okay, somewhat heterogeneous on the T2 weighted image. This is showing you an X-ray of a giant cell tumor of tendon sheath adjacent to the proximal phalanx. Grossly, this is how it would look on clinical examination. Just an isolated enlargement in the area. This is what the MRI appearance, T1 weighted and T2 weighted MRI. You can see where this tumor has eroded into the bone. This is a T2 weighted MRI of a giant cell tumor of tendon sheath. Histologically, it consists of a localized or diffuse proliferation of synovial-like cells, giant cells, inflammatory cells, and xanthoma cells. So you really want to be looking for the hemosiderin, the synovial-like cells, and the giant cells. and the xanthoma cells. Okay, same histology as pigmented villonodular synovitis. And you can see here, this is what PVNS looks like. Here are your xanthoma cells, or your cholesterol-laden macrophages. Okay, here's your synovial-like cells over in this location. Okay, you have blood vessels within giant cell tumor of tendon sheath, and you should be looking for hemosiderin deposition. So xanthoma cells, synovial-like cells, okay, the very hypercellular tumor, and looking for hemosiderin deposition. Some giant cells may be scattered throughout. Here's a giant cell, here's a giant cell, here's our giant cells scattered throughout the synovial-like cells. Okay, I don't see any hemosiderin deposition. Some inflammatory cells which have infiltrated some blood cells, synovial-like cells, and some giant cells in this location. This is showing you the foamy histiocytes, or the cholesterol-laden macrophages with the synovial type cells. Some collagen production. Okay. Pigmented villonodular synovitis is another benign type of tumor that affects the joints. It arises from the synovium. Usually involves the large joints, and 80% of cases occur in the knee. Presents with a joint effusion and often pain or mild discomfort. It's usually a diffuse synovial process with the pathology similar to giant cell tumor of tendon sheath. Although there are two varieties of pigmented villonodular synovitis, both the diffuse and the localized type. Diffuse type will involve the entire joint. Localized type will consist of a single nodule. Consists of synovial hyperplasia with multinucleated giant cells, and there's intra and extracellular hemosiderin deposition. An MRI will show you an effusion or a mass may be seen on radiographs or an MRI. It can fill a Baker's cyst also and extend down into the thigh as its leg or upward into the thigh, as you see here. It can erode into the adjacent bone. Erosions can be found on 50% of cases, and much more common to have erosions in smaller joints such as the hip and the shoulder than in the knee. Erosions are usually geographic or lytic with a sclerotic rim. Joint space is usually preserved, although it does erode the cartilage. And most cases that are identified nowadays are identified before there's massive destruction of cartilage in the bone. But in earlier years, this would erode into the bone would fracture, it would destroy the joint. Some people even ended up with amputations. It can extend into the soft tissues and around the neurovascular structures also. These tumors do not calcify. Calcification is very rare, and possibly they may have increased attenuation on a CT indicating the hemosiderin deposition. So in the MRI, you see heterogeneous synovial mass extending away from the joint. Okay, you can see here's an intra-articular mass with both components anteriorly and posteriorly. Signal intensity is less than or equal to muscle on the T1 and T2 weighted images. There's scattered high signal areas on T2. Cystic lesions occur uncommonly in the bone, but the bone can be involved and have cystic cavities within it. And there's blooming on gradient images indicating hemosiderin deposition. So this mass constantly is irritated in the joint or traumatized, and it bleeds a little bit, and you get the blood product called hemosiderin. It gets deposited in the tissues. Hemosiderin appears dark on a T2 weighted image, and on blooming images gets even darker. This PVNS is actually treated in different manners. Usually it's with usually surgical excision is the mainstay of treatment. However, there's a very high local recurrence rate, anywhere from 80 to 100%. Approximately 80 to 100% of these tumors will recur after a radical anterior and posterior synovectomy. So if you have a diffuse variety of PVNS, you would treat it with a radical anterior and posterior synovectomy. Radiation may be considered for local tumor control, and that may reduce the local recurrence rate less than 10%. For nodular or isolated pigmented villonodular synovitis, there is just usually an isolated area either in the front or the back of the joint, and that rarely recurs, and you would not consider radiation for the treatment of a nodular or an isolated PVNS. I want to thank you for listening to this lecture. I hope you learned a lot, and this concludes our lecture on benign soft tissue masses. These are the most important soft tissue masses that you'll be tested for on your OITE exam and for your orthopedic boards. For more information on musculoskeletal tumors, please visit my website at www.tumorsurgery.org. Thank you.